Hi everyone. I would like to thank Vijay for giving me this opportunity. However, so when actually Vijay asked me to deliver this talk, the radiation local therapy related endpoint for brain metastasis, I scratched my head and saw and went back to the studies that has been done in brain metastasis, especially from lung cancer, because I deal mostly the lung cancer cases. So the flow of my talk will be I would be talking in terms of the radiotherapy endpoint. I'll try to put it in terms of perspective from 1990s to 2020. What has what had the endpoints in the radiotherapy related brain metastasis trial, and what endpoint should we choose for the future studies. For example, if we want to design any studies and the future trial and their endpoint. I am not going to detail about the future trial because the time will not permit me. So let's talk about something which has already happened in the past. So this is the first randomized control trial which has been published in brain metastasis. So Pachel et al. In the year 1990. At that time, whole brain radiation therapy was the only treatment modality for brain metastasis, and they challenged that dogma, especially in a single brain metastasis with the whole brain radiation therapy versus surgery followed by WBRT. And you look at the endpoint, they did not select only one single endpoint, they selected functional independence, the recurrence and survival. And what they found at that the surgery followed by WBRT has a better chance in improving all the endpoint as compared to whole brain radiation therapy alone. So from that particular trial, for a single brain metastasis, the surgery followed by WBRT has become the standard of care in place of WBRT alone. 8 years later, the same author, the Pachel et al., has concluded, has continued about the surgery plus WBRT versus surgery alone. They challenged the role of WBRT after surgery. So what they found out, the primary endpoint was local recurrence, and they found that time to local recurrence was longer with WBRT than observation. Hence, that means the surgery followed by WBRT was the standard of care for a single brain metastasis. Now the authors went ahead, so one step further. They say only whole brain radiation therapy will not be good enough. We need to give boost. So whole brain radiation therapy with or without stereotactic radiosurgery boost in approximately 1 to 3 brain metastasis. So what they found with the primary outcome of overall survival, the overall survival was not different when they look at the entire cohort of 1 to 3 brain metastasis. But when you look at the only population of one single brain metastasis, so in place of WBRT with boost, they have shown a 4.9% versus 6.5 month of overall survival difference. So that's why the standard practice has changed from WBRT alone to WBRT with boost. That boost may be 9 gray or 15 gray, so depending upon the institutional practice. Now coming to that, then the era of stereotactic radiosurgery came. So the authors, the Aoma et al. From the Japan and the China, they decided to do the randomized control trial in 1 to 4 brain metastasis, because at this particular time the neurotoxicity of whole brain radiation therapy was coming into the picture in multiple prospective studies as well as the randomized control trial. And they have decided that we will do a randomized control trial with the primary endpoint of overall survival. And what they found at that, the primary endpoint of overall survival was not different between WBRT followed by SRS versus the SRS alone. But mind you, WBRT treats the entire brain, whether there is a disease or not at that particular site. But SRS is a very focal sort of a treatment. It will treat only the brain metastasis and not the normal area where could be a microscopic disease present. So the distant brain control 1 year brain tumor recurrence 1 year rate of developing new brain metastasis was all higher in case of only SRS. So WBRT plus SRS was the standard of care for 1 to 3 brain metastasis. But the drawback was they challenged the role of WBRT, but they did not do a formal neurocognition evaluation. It is very important to do a formal neurocognition evaluation when you want to omit WBRT from the treatment arena. Now coming to this particular trial, they did a primary endpoint of cognitive deterioration at 3 months. The same design, 1 to 3 brain metastasis, SRS plus WBRT versus the SRS alone. And what the authors found out that there was a less cognitive deterioration with the stereotactic radiosurgery as compared to whole brain radiation therapy. We know that SRS will give a less cognitive deterioration, but we need the evidence to be put there. So there was a less cognitive decline with SRS. The quality of life was higher with SRS. There was no difference in functional independence, but there was no difference in overall survival, because when you do have SRS, then there is a possibility that that patient will have a distant brain tumor recurrence. For that, you can offer them WBRT or stereotactic radiosurgery, or for example surgery, if the patient condition is good. Now coming to the post-op setting. As you see, so in a post-op setting in 1 to 3 brain metastasis, when you have done a surgery for a single metastasis versus the 1 to 3 unresected brain metastasis, so the primary endpoint in this particular trial was time to WHO performance status deterioration to more than 2. The randomization arm were WBRT versus observation. So here the authors find out that the median time to performance status deterioration was not so different in both the arms. The overall survival was also similar. So they decided the WBRT, however, the WBRT reduces the intracranial relapse rate, intracranial progression rate, as well as the salvage therapy rate, because of the obvious reasons. Now, the next trial, obviously, they also did not do the formal neurocognition evaluation. So there was a need to do a formal neurocognition evaluation when you want to omit the whole brain radiation therapy in the post-operative setting. So this Brown et al. Paper, which was published in Lancet Oncology in 2017, they were smart enough to do a co-primary endpoint. First one was the cognition-free survival, and then was the overall survival. And the cognition-free survival was defined as a drop of greater than 1 standard deviation from baseline. You can see post-operative SRS versus the WBRT. And what they found out that at the 6th month, the cognitive deterioration was less frequent in SRS than WBRT, and the median overall survival was more or less the same. So in terms of cognition, the SRS was better as compared to WBRT. So in a post-op setting, when you have one site is resected, it is advisable to give post-operative stereotactic radiosurgery if you want to preserve the neurocognition with a similar overall survival. However, the one point to be noted here is that whenever you give post-operative stereotactic radiosurgery for SRS, there is a shorter time to intracranial progression. The disease might come at a non-treated area. Now, the authors by Mahajan et al., they decided to compare both the good arms of the previous 2 randomized control trial, post-operative SRS versus the observation. Now the primary endpoint here is time to local recurrence, because one of the treatment arm is observation. Here we are not offering any treatment. So first endpoint should be, the primary endpoint is time to local recurrence at the resection cavity. There was also a neurocognition evaluation done, but which is not published yet. So here they have said that the median time to local recurrence is not reached in the SRS arm versus the observation. So in any post-operative setting, you cannot observe the cavity. You need to offer at least SRS or WBRT. Time to distant brain recurrence was similar. The median overall survival was 17 versus 18 months. So we have seen that over a period of 20 to 25 years, the radiation therapy related endpoint has changed from overall survival, from time to local recurrence, from neurocognition to functional independence. So there was one more randomized control trial in a poor performance status about challenging the role of WBRT versus WBRT plus optimal supportive care. The arms were WBRT plus optimal supportive care versus optimal supportive care alone. Here the primary endpoint, because these are poor prognostic group of population in approximately 80% of the patient, the primary outcome was quality adjusted life year. Here there was no endpoint like the local recurrence or overall survival. Here the endpoint was quality adjusted life year. And it was a non-inferiority design, and the authors concluded that the quality adjusted life year in both the arms were not very different. And they said that in the poor prognostic group of population like GPA 0 to 2, if you do not have a good performance status, then you can omit the WBRT and just give the corticosteroids. So there is a hippocampal avoidance. There is a lot of talk about the neurocognition deficit in the WBRT, and the memantine can be used for the preservation of neurocognition. There has been a very good papers about the hippocampal avoidance, but there was not a phase 3 randomized control trial. So recently in JCO there was a trial published by Brown et al. Where they have said that hippocampal avoidance with a time to neurocognitive function failure is better when you preserve the hippocampal, and if you do not irradiate the hippocampal areas. So Now coming to what endpoint should we choose for radiation therapy related endpoint, it's primarily and importantly dependent on the objective of the study. What are the modalities that you are doing, or what are the modalities that you want to compare? So so majorly the radiation therapy is a focal therapy, so it will have an impact on local recurrence or intracranial progression free survival, neurocognition, especially in the whole brain radiation therapy arm. Last is the overall survival. The whole brain radiation therapy or SRS is not going to have an impact on the overall survival predominantly, because the lung cancer is predominantly a systemic disease. So to put an overall survival type of an endpoint, when you want to have so difference between the two treatment technique or two treatment modalities of the radiation therapy will not be a wise idea. So the better idea would be to put a local recurrence or intracranial progression free survival. There was a lot of talk about the asymptomatic brain metastasis patient in driver mutation population in the previous session. So we decided it's just not to wait for the evidence to come to us, and we should generate the evidence from the Tata Memorial Hospital. So we decided to conduct a randomized control trial between observation or upfront cranial RT versus delayed cranial RT in asymptomatic driver mutation population. And what we chose as in primary endpoint is intracranial progression free survival, because we are not offering any sort of radiation therapy, and we are offering the radiation therapy at the time of progression. So we decided to choose the primary endpoint of intracranial progression free survival. Yeah, so this was my last slide.